All right, it is 8:30 on the east, 5:30 on the other coast. So to be respectful of everyone's time, we're going to get started. If you are logged on, this is the National Sports Medicine Fellow Online Lecture Series, sponsored by the AMSSM Education Committee, as well as with the Fellowship Committee as well. Just as a reminder, the purpose of this committee, really subcommittee, in these lectures is to serve as an adjunct to your individual program's educational programming, and it's really to provide our sports medicine fellows with direct access to educational experiences with top AMSSM members in a variety of formats, and really to assist in the CAQ exam preparation process. If you have not done so already, please mute your device's microphone. You're more than welcome to stay on video, but at least mute the microphone. Please submit questions through the chat function, including your name and program if you wish. I will try, as moderator tonight, I will try to monitor that while Dr. Leber is speaking. Additionally, after the program, please complete the evaluation, which Andy Meyer will graciously put into the chat box with a few minutes to go. So tonight, we're very fortunate. We're going to talk on distal forearm and carpal fractures. My name is Jason Zaremski, and I'm the moderator. I'm at the University of Florida. And we're fortunate to have Dr. Melissa Leber speaking tonight. Dr. Leber is an associate professor of both emergency medicine and orthopedics, and is the director of emergency medicine and sports medicine at the Icahn School of Medicine at Mount Sinai. Yes. Sorry about that. That was my 6-year-old bombing the call. Sorry. She is the player physician at the US Open, as well as the airway physician for the New York Jets. And she's also a medical consultant for the NBA. And she's also a team physician for the Horace Mann School. Without further ado, and hopefully no more of my kids will bomb the call tonight, I will unshare and allow Dr. Leber to share her slides.
Hi, everyone. Hopefully you can see my screen. So I am Dr. Melissa Leber. Thank you so much for that introduction, Jason. And I have kids myself, so I totally understand the video bombing, Zoom bombing, whatever you want to call it. So let's get right down to the nitty gritty. I know you already heard all this about me. I am emergency medicine trained and did a primary care sports medicine fellowship. And currently I do 70% orthopedics, 30% emergency medicine at the Icahn School of Medicine at Mount Sinai. And my email's here. Feel free to email me at any time with any questions, either during the lecture or after the lecture. But of course, I am pretty informal, and I would love if, Jason, if you see any questions pop up in the chat, or if anyone wants to unmute themselves if they have a question, I'm happy to take questions during the lecture, because I'd much rather answer them when they're applicable to what I'm talking about. So some very basics on fractures. And the reason I included some basics is because I think a lot of us come from different training and different backgrounds, and some of this will be more basic than what some of you need, and some of this will be more advanced. And it depends on what your practice will be. But hopefully all of you will find it somewhat helpful. So for bony healing after a fracture, what I want you to know is that it really takes up to a full year to achieve real bony healing. But initially, in the first 2 to 3 weeks after injury, there is some evidence to show that taking NSAIDs can delay healing. And that's where all of our surgical colleagues get that from, where they don't like to give NSAIDs right after the fracture, because there is some evidence to show that it can hurt osteoblast activity, which is very vital in the first 2 to 3 weeks. So fracture management in kids versus adults. In skeletally immature, most get casted. They have a lot of fracture remodeling and reshaping. They get rapid healing. And based on the physis level, Salter-Harris level, and how advanced their bony growth is, depends on how much deformity they will get. Whereas when you're an adult or skeletal mature, they're splinted for shorter periods of time because they get more stiff. The anatomic alignment is even more important, and they have slower bony healing. So if anyone on this call could call out some very common fracture complications that they know of, that would be helpful. I'd love to be more interactive.
Non-union.
Great. I heard non-union.
Across the growth plates.
Okay, like involving the physis, you're saying, yep.
Malunion.
Malunion is another good one, yep.
Avascular necrosis.
Avascular necrosis, great. One other big one that we measure something if someone comes in due to excessive swelling.
Compartment syndrome.
Yep, awesome. And then there's another really rare one, fat emboli, where we said non-union, malunion, osteomyelitis, of course, and AVM. All right, so what factors from the patient's history increase risk for AVM? Like what about them can increase their risk that should make you more worried?
Steroid use.
Steroid use is a good one.
Smoking history.
I don't know that smoking history is definitely included, but it probably is. It's bad for everything. But one other big one that we see, especially in emergency medicine, of patients coming in mostly undomiciled.
Sickle cell?
Yeah, I guess sickle cell would, did it put you at increased risk for AVM? I don't know about that one. I was going for a steroid use, alcohol abuse, and pregnancy, put you at increased risk. And what are some high risk fractures? I know in this talk is only about carpal bones. So there are 2 carpal bones that you got to worry about that are high risk for AVN. If you can list those 2.
Scaphoid.
Yeah, scaphoid. And one other, not as common.
Lunate.
Yes. Wow. Awesome. The person who said lunate, do you know the other name for that?
Kienbock's.
Yeah, I think it's Kienbock's, but maybe it's Kienbock's. Yeah. Awesome. Kienbock's disease. And then can anyone else list the other high risk fractures for AVN that we commonly look for on physical exam? If someone injures their foot, for example, there's 2 in the foot.
Second metatarsal.
Not the second metatarsal.
Navicular.
Talus.
I heard someone said navicular. That's perfect. And one other one.
Jones fracture.
Yes, the proximal 5th metatarsal, or Jones. Perfect. And then the other one is femoral head. So there's a list of the high risk fractures. So anytime someone comes in with, for example, a wrist injury, you want to always, keep an extra lookout, as we know, for scaphoid and lunate fractures, but also don't forget Jones fracture and navicular fractures in the foot, because those are also high risk for AVN and poor healing. I see if someone can interrupt me, if you use anything in the chat. I see there's 2 things in the chat, but feel free to interrupt me with questions, okay? So it's very important to have a good documentation with any fracture. I think that goes without saying, but just to review and be complete, you want to make sure there's no signs of infection. Is it open or closed? Are the compartments soft? How is the joint above and below the fracture? And just a full neurovascular exam. So just when you're documenting, you got to be able to name the bone, obviously metatarsal, femur, which carpal bone, radius, whatever it is, the location of the bone, and where it is on the bone, whether it's an open, closed, or intra-articular fracture, and whether it's non-displaced or minimally displaced, or displaced, and the fracture angulation. So why should we, this topic, you got the email today, you're probably like, ugh, I really don't want to log on to listen to carpal bone and wrist bone fractures, because how exciting is that topic? It's not super glamorous. And I really do like to make the lectures interactive and more exciting, but why should you care about this lecture? And the reason you guys should not fall asleep, and the reason you should really care, is because it actually accounts for 20% of all ED visits for injuries, hand injuries and wrist injuries. So not that all of you work in the ER, but you should know that a lot of people injure their hands and wrists. And it's more common, or costs more, than any other injury type. And the reason it costs more is because it leads to missing work, it leads to lost productivity, certainly costs in healthcare, and certainly easy disability. So anyone who injures their hand and wrist, if it's long-term, or even if it's not, sometimes it can lead to disability from their current job or their current sport or whatever they're doing. So this is super important. You don't want to miss injuries, and you want to manage them appropriately. So I think this is a good lecture for you all to really focus on. So one point that's super important is that I want you to be able to differentiate the hand from the wrist. And it also helps you to decide when to get hand films and when to get wrist films. So if you look at the screen between the 2 green lines, that's when you get a hand film or a finger film, because any injury to the fingers or the metacarpals includes the hand. Then in this talk, I'm just going to talk between the bottom 2 green lines, any pathology that includes the radius, the distal radius, the ulna, and the carpal bones. And that's when you get a wrist x-ray if they have a wrist injury. Or if you're not sure, of course, you can always do both, which patients love getting more x-rays. So first case, I think the total talk has 6 cases. But the first case is a 45-year-old slip and fall on ice. How common is that? She's right hand dominant, immediate right wrist pain, and there's swelling, there's decreased range of motion. It's a closed injury, neurovascularly intact. And here are her x-rays. Can anyone call out what they see?
Distal radius fracture.
Amazing. Is it intra-articular or not? Is it shortened or is it not?
It's intra-articular and shortened.
Yeah, it does look that way. Perfect. Okay, so you got that right, distal radius fractures. So it is the most common orthopedic injury. Of all orthopedic injuries, distal radius fractures are more than any other injury. And it accounts for 70% of all fractures in adults, most commonly fall on outstretched hand. So what I want you to know about the anatomy is the different articulations, because it's very important to understand this blue box and what's within it, because that'll help you determine the management. And some of this, is a little bit nitty gritty. You don't need to know it for details of everyday practice. And obviously the wrist and hand surgeons do, but if you're going to be managing on these on your own in the community, or you don't want to have to refer them all out, I think it's important to know. So there's the lunate facet that articulates with the lunate bone facet, and the scaphoid facet that articulates with the scaphoid. So those are the 2 main portions on the radius. And what I want you to know about those is that intra-articular portion is very important. And when you document it, it's good to know, is it articulating with the scaphoid or the lunate, as that can lead to further arthritis, especially if it articulates with the scaphoid. And then you want to also look, if you can see my mouse pointing here, at this radial ulnar joint as well. It's called the DRUJ, or distal radial ulnar joint, to make sure there's no widening in there. And this is the ulnar styloid. And that's the main anatomy you need to know for the distal radius fractures. Other types of distal radius fractures, the most common would be the Colles fracture. But there's also the Barton's and Smith's fractures. And here's another view of Barton's and Smith as well, just to explain the different types of fractures there are. So treatment options for distal radius fractures. There is non-operative, which is what we would all be specializing in. And then there's operative, pretty simple, right? And these are the different types of surgeries that can happen. I know that you don't need to know the names of all these different surgeries, but just know that a lot of different options exist. And so you want to have a hand surgeon that you're referring to that really not only knows what they're doing, but that's up on the latest and greatest treatment options. So for the non-operative, because that's what we're mainly focused on, for the non-operative treatments, that would be mainly casting or splinting. And for the surgical option, the volar locked plate is the most common way to treat it. Okay, so it's important to know what predictors make you more worried about the distal radius fracture. And based on this study, basically every hand surgeon follows from this study that fracture instability is based on age greater than 60 years, if there's more than 20 degrees of dorsal angulation, any comminution of the fracture, if it's intra-articular, and if there's an associated ulnar fracture, makes it more worrisome. And so these are the cases that you are more likely to refer out. If there is no displacement and no angulation, much less likely, and we're going to cover that. So I will tell you that when you look up the literature, it's not super straightforward on whether to manage these non-operatively or with surgery. And so a lot of it depends on a few factors. So if you go to the AAOS, American Academy of Orthopedic Surgery guidelines, these are the guidelines that they say, but they will say that they're not able to, they had a work group to help decide who should have surgery and who shouldn't, and there was a lot of disagreement. But one thing they did agree on is that if there's more than 3 millimeters of radial shortening, more than 10 degrees of dorsal tilt, or a large step off more than 2 millimeters, then they should have operative fixation. And that if they're treated non-surgically, then you should follow them with weekly x-rays for 3 weeks, because a lot of the fractures move with time. And so you want to make sure that if they are moving, those might need surgery as well. These are the major radiographic parameters that you need to know in terms of measuring the radial height between the blue lines and for radial inclination. So you want to measure, I don't expect many of you to be doing this in your office unless you really want to practice this independently. But if you're ever not sure, I'd probably refer for surgical consideration in these cases. So now what? You have a patient with distal radius fracture and you want to reduce them or manage them in your office to at least get them more comfortable, to splint them and to get them either for non-operative management or to the local hand surgeon. And so the first thing you're going to do is a hematoma block. So you're going to take about 8 to 12 cc's of lidocaine and you are going to inject it into the distal radius right at the fracture site. So you want to aspirate and make sure you're not like in the artery, but you want to aspirate. You can get back some blood because that's hematoma, and then inject as you go into the fracture site. And that would be for pain control so you can reduce them more easily. It's ideal to have finger traps because if you have finger traps, you just have them hold their arm up and fatigue the fracture, which will allow you to reduce it much more easily. Because a lot of times, as you can see in this picture A, that fracture fragment can get caught on the proximal fragment. And then if it's displaced, you're going to put them in a sugar tongue splint. And so we're going to go over splinting at the very end of the talk, but there's a lot of also discussion in the literature whether they need a sugar tongue splint or not. If it's a non-displaced fracture, they do not need a sugar tongue splint. Then they just need a short arm volar splint. But if it is a displaced fracture, the sugar tongue will help prevent pronation, supination, flexion, extension of the wrist, which will help for stability once you reduce them, but also help with pain control. The negative of the sugar tongue splint is that you're not only immobilizing the wrist, but also immobilizing the elbow. All right, I'm just gonna look and see in the chat. Okay, so someone said for NSAIDs, at what age do you start to not recommend against taking it for pain control? There are some articles that state pediatric patients who take NSAIDs will not delay growth. So, I mean, in terms of fracture healing, that's one thing, that the evidence shows not to take it in the first 2 weeks after a fracture. But for pediatrics, and I'm sure there's more peds experts on here than I am, I do give NSAIDs for pain control. I have not heard about that delaying growth. So someone speak up if I'm wrong on that. Should you try to reduce radial fractures if the patient will need operative fixation? If the patient is not in pain, or should you splint it? Definitely reduce it. It's much better to put them back in line than have them not reduced at all. You don't want to splint an unstable fracture or a displaced fracture. So try to put them so the bone is placed back into alignment before you splint it. Hopefully that answered the question so far, but thank you for those questions. Okay, so case 2, 23-year-old male football player fell on his wrist and now presents with swelling and pain of the right wrist. He's tender everywhere and has x-rays that are normal. So what would you guys do next? Normal wrist x-rays, tender everywhere.
Depends on where he is in his season. I might splint him if he's at the beginning of the season and get more aggressive with my imaging if he's right before championships.
Okay, fair enough. Was that, I think, Luke who said that, right?
Correct.
Okay, and at the beginning of the season, you would splint him and do what? Follow him up in a week or 2 for repeat x-rays?
Yep, and see if there's any bony healing and identify now where his pain localizes.
Got it. Okay, and what Luke or anyone else would you think that this patient has? What injury? What would you suspect in a 23-year-old football player, wrist swelling but normal x-rays?
Would certainly be worried about a occult scaphoid fracture.
Yeah, and of course this is a talk on carpal bones and wrist and distal radius fractures. But yes, we have to be worried about scaphoid fracture. And so we're gonna go over, by the way, if you look at these 4 choices, the only one that's really wrong is A and kind of D. And I'm going to tell you why. But A is definitely wrong because you definitely want to splint him if he had a wrist injury and has swelling because you suspect there might be an occult fracture that was not seen on initial x-ray. So, you want to either see him back and repeat x-rays or get an MRI of the wrist, which is the most sensitive modality initially to pick up an occult fracture. But in this athlete, there is a scaphoid fracture. I'm just showing you here a different, how a scaphoid fracture would look on X-ray, CT, and MRI. This is this patient's X-ray. And so you can see here, I don't know, hopefully you guys can see my mouse pointing, but you can see the scaphoid fracture. So what you need to know about scaphoid fractures, the exam is notoriously unreliable. They get a lot of swelling, but the deformity is rare and bruising is rare. And X-rays are normal in up to 25% of cases. That's a large number of cases that have normal X-rays, but even though they have a fracture. And that's because it doesn't ossify right away, and over time will show the fracture later on. You can try to do 2 different X-ray views, which I'll show you in a second, the ulnar deviation on X-ray or clenched fist. And also in terms of whether to get a CT or MRI, if you have access to do that, like as Luke said right before the championship game, the MRI is definitely more sensitive for occult fractures. And the CT scan is typically used more to assess for displacement and healing later on. So this is this football player's lateral MRI, and here's his coronal view of MRI. And so here he is after he had it repaired, and here he is after post-op, showing his range of motion, how he did. So here's the view, ulnar deviation view, which can sometimes help see the scaphoid fracture better, as well as a clenched fist view, which can sometimes help. That's also used for scapholunate disassociation as well. So basics of scaphoid fractures. It accounts for 70% of all carpal bone fractures. So, you know, most carpal bone fractures you're going to see are involved with scaphoid. More common in males. The classic mechanism of injury is an axial load with wrist extended with slight ulnar deviation of the wrist. And it can be a high energy fall or a low energy fall. The ones we typically see are more in athletes, especially football players. And I'm sure you all know this, but focusing on where the scaphoid is fractured is actually quite important. And this is even important for your CAQ boards. This could be tested on, I know it's definitely on emergency medicine boards, but definitely on the CAQ for sports medicine boards, which I know is important for everyone. So it's important to know where on the scaphoid is higher risk for ABN. But the more common fracture is in the waist of the scaphoid, which I'm going to show you on the next slide. And then most common is the distal pole, and the least most common is the proximal pole and the tubercle. So what does all that mean? So if you look at this picture, the distal pole accounts 100% is referring to the numbers that heal. Almost 100% of distal pole fractures heal well because of the blood supply, which I will show you in a couple of slides. Then the waist refers to the middle portion of the scaphoid, and the least likely to heal is the proximal pole, which refers, that's showing you 32% heal. And so what's the vascular anatomy of the scaphoid? So the dorsal branch of the radial artery accounts for 70 to 80% of the vascular anatomy of the scaphoid, and it comes over the dorsal oblique ridge, which I know you don't need to know that term, but it basically is in the proximal pole, supplying the proximal pole. Whereas the volar branch of the radial artery really applies the tubercle, which is also not the I misspoke. The distal pole is what the dorsal branch supplies. And the volar branch supplies the tubercle, which is also at the distal pole, and accounts for 20 to 30%. So, you know, what is supplying blood to the proximal pole? Very little. There's a little bit of intraosseous blood supply to the proximal pole, but in general, it's a vascular watershed area, and that creates a very poor fracture healing environment. So the scaphoid is classically referred to as appearing like a boat or a twisted peanut. And this is how it looks on 3D reconstruction. It is definitely an odd shaped bone, but it explains, if you can see how the tubercle points out how patients can injure it so easily. It's the only carpal bone that spans the proximal row and the distal row, and 70% of it is taken up by articular cartilage, which is also one of the other reasons for its poor healing. And it articulates with the radius, the lunate, the trapezium, the trapezoid, and the capitate. So it plays a huge role in the wrist. So physical exam. It's good to know the provocative test. I think we've all heard of the anatomic snuff box. And so you can palpate the anatomic snuff box. You can palpate the scaphoid tubercle. I'm going to show you pictures of this in a second. And there's the scaphoid compression test, which is axial loading your thumb, axial loading your thumb. And when all three tests are positive, it has an 87 to 100% sensitivity if you do those physical exam within 24 hours of the injury. So let me repeat that. If they are tendered with all three of these exam findings, then it's pretty sensitive to say that they likely have a scaphoid fracture. So here's your anatomic snuff box. You can all palpate it on your wrist so you don't forget that, excuse me, where that is. And also palpate the scaphoid tubercle. That's volarly. That's the point I showed you on the 3D reconstruction that, is a little bit sticking out on the volar aspect, which when you have a foosh injury or fallen outstretched hand, that can injure it more likely. And the last one is axial loading the thumb, which also can cause pain. Now keep in mind, if it's an older patient and they have any kind of CMC arthritis of the thumb, that's also going to hurt them because that's like a CMC grind test, basically. So, be discerning with your physical exam. So management, which we already slightly talked about, but non-operative management for scaphoid fractures is going to be if there's less than 1 millimeter displacement on CT, because 90% of them will heal and do well in a cast. The casting is typically, I think I'm covering that in a second, but the casting is typically for 8 to 12 weeks. And then definitely surgery if they're more than 1 millimeter displaced or have an unstable fracture. If there's any comminution, the flexed fracture posture means that the bone is kind of, where it's fractured, the bone is actually displaced in a flexed position, or if it's a fracture of the proximal pole because of the high risk for ABM. So what is controversial is actually for, what type of surgery they should have. I know that doesn't really relate to us as much, but also whether we should do a thumb spica with a sugar tongue, which is above the elbow, or whether you can do a short arm cast with the thumb free. And actually the literature is equivocal. So I say immobilize less, just do the short arm cast with the thumb free rather than immobilizing the elbow as well. But there are a lot of surgeons who don't believe that and would take the image on the right over the image on the left. But if I was the patient, or if it's an older patient where you don't want them to be stiff, I would take the image on the left. And this was one of the studies that showed there really was no difference in the short arm cast versus a thumb spica versus a sugar tongue splint. So to review what we're talking about, the distal pole and the tubercle, that has 100% healing. And you can, if it's non-displaced, you can cast them for 8 to 12 weeks and repeat x-rays repeatedly, but usually they do quite well. I put 2 stars next to the cast for 8 to 12 weeks. And that's because if they are an athlete, or an elite athlete, I should say, a lot of those will choose to have surgery regardless. And that's because they would only need treatment or casting for 6 weeks or less. So they heal faster and they're back to their sport quicker. Fractures of the waist depends. And it can go either way. If they're displaced more than 1 millimeter, then they were more likely to be fixed operatively. And fractures at the proximal pole should have surgical fixation because of high risk for ABN. So bottom line, if you weren't listening to anything I said so far about the scaphoid, memorize this slide, look up at the screen and know that the distal fractures of the scaphoid are non-operative treatment as long as it's non-displaced. The waist fractures depends, and the proximal pole usually has surgery. Classic complications of scaphoid are non-union, and high risk for non-union is if they delayed treatment more than 4 weeks, so they didn't come in for 4 weeks, if they have a proximal pole fracture or a vertically oriented fracture, meaning it's not a transverse fracture across the bone, if the fracture is displaced more than 1 millimeter, osteonecrosis, ABN, tobacco use, all of those make it higher risk for ABN, higher risk for non-union, as well as chronic arthritis is a common complication of scaphoid fractures, which can lead to the dreaded complication of SNAC, S-N-A-C-K, and S-N-A-C, not S-N-A-C-K. I'm thinking about food. Scaphoid non-union advanced collapse. All right, I'm going to see what that question is in the chat, and then we can go on to case 3. I've never had a pediatric patient require any pain meds after day 2 if properly immobilized. That's a really good point, Johnny. Kids do so well once they're immobilized. So it's a very good point. All right. So this next case could be from either of these pictures. Pretty bad angle of injury and pretty high velocity injury, as you can see in both of these pictures. And what does anyone see is the problem on these x-rays? Anyone? Okay, perilunate dislocation. I'm going to show you how to detect this. And it's much more easily seen on the lateral view of the x-ray. And the common complication is a median nerve injury or a concomitant scaphoid fracture. And these ones need a hand consult in the ER, less likely going to be coming to outpatient practice. So how do you tell the difference between a lunate dislocation and a perilunate dislocation? So if you look at this image here on the left, we like to think of the radius as the saucer, the lunate as the coffee cup, and the capitate as the sugar. And these should all be in line when you look at a lateral x-ray. If there is a lunate dislocation, then the cup has spilled over. And if it's a perilunate dislocation, then the sugar is out of the cup. All right, does everyone get that? So if we go here, if someone could call out this image here on the left, is that a lunate dislocation or a perilunate dislocation?
Lunate.
Amazing, you got it. All right, you're gonna have another chance to guess. Is this image that I just pulled up a lunate or a perilunate?
Perilunate.
Yes, perilunate. Now it's easier if you see both side by side, but here on the left, you can see that the cup is still in line with the saucer, but the sugar is out. So that's perilunate, whereas here, the cup is spilled over, and that's a lunate dislocation. So these tend to be more in men in their 20s and 30s, high energy. 25% of cases are originally missed, and that's because you have to look really at the lateral film and then sometimes the AP and the oblique can look normal if you don't look at the lateral. And it accounts only for 7% of carpal bone injuries. And if you're not sure, get a CT, especially with high speed injury. All right, does anyone know what's in this picture?
Scapholunate dissociation.
Yes, awesome. And what's the common complication? Like if this doesn't get treated, what can you get?
Slack wrist. Dizzy?
I think both of those are correct, both forms of chronic arthritis. I didn't get into the fancy details. And so for these, they can be put in a short arm volar splint, and a lot of times these are repaired surgically. I mean, if it's someone who's older with a scapholunate dissociation, they may choose not to have surgery and just deal with the pain. But all right, so it's often called Terry Thomas sign. And if you suspect it, meaning they're tender over that scapholunate ligament, then you may want to get that clenched wrist view again, which can show widening with clenched wrist. Okay, so does anyone know what they see on this? This is a carpal bone fracture with the arrow. Does anyone know what bone that's referring to?
Triquetral fracture.
Yes, awesome. So triquetral fracture. It's the second most common carpal bone fracture after scaphoid. Complications are rare. Oftentimes it's a fawn outstretched hand. And they're tended to palpation just distal to the ulnar styloid and the TFCC, mostly treated non-operatively with a volar splint cast. All right, does anyone know what fracture is here? What carpal bone? Not as common.
Is it a hamate?
Yeah, a hamate fracture. So I'm just trying to make sure we're on time here. So hamate fractures are rare, only accounting for 2 to 4% of all carpal bone fractures. And they're associated with fractures of the 4th and 5th metacarpals, commonly in gripping sports, like when you ground a golf club, for example. If it's non-displaced, they're non-operative. These have high non-union rates. So if you suspect it, get a CT because 40%, 50% don't heal well and end up having surgery. The hook of the hamate is slightly more common than the body of the hamate. These are really hard to see on x-ray, so you have to suspect it. And these are the different x-rays that you can get, or you can just get a CAT scan. Oh, that's what I wrote. If clinical suspicion, get a CAT scan or MRI. So the motor branch of the ulnar nerve passes right beneath the hook of the hamate in Guillen's canal. And sometimes patients get an ulnar neuritis, like a chronic ulnar neuropathy. So you can excise the hook of the hamate if it's causing problems. So that's all I have on the actual cases and fracture. I was going to switch gears to splinting. Let me see what, oh, someone guessed. Alan guessed dislocated lunate. Thank you for that. Sorry, I wasn't looking at the chat. So I don't know how much knowledge everyone on this call has about splinting, but I did want to cover some degree of splinting because I thought that it would be good to have an idea, because I don't know how many of you are emergency medicine or not. But so for splinting, they're used to maintain position and correct a deformity. I think that goes without saying. The joint should never be immobilized unless they are actually serving a purpose, because we see people immobilizing joints all the time that get stiff. The older the patient, the more stiff they get. And especially since we're talking about wrist and hand in this talk, if you mobilize, like the PIP joint, for example, gets extremely stiff, and the elbow too gets extremely stiff. Oh, I wrote that there. So in 1875, Sir James Paget said, with rest too long, maintain the joint becomes stiff and weak, even though there be no morbid process in it. And this mischief is increased if the joint hath been too long bandaged. So they even knew this in 1875, that you shouldn't immobilize joints that don't.
So I think we lost the video feed. I think people were trying to log back on. So Dr. Leber is probably trying to log back on right now. While she's trying to do that, are there any questions so far that I can try to answer, or anything logistical? One thing that I was going to bring up is, oh, there she goes.
Hi, everyone. I'm so sorry. I don't know what happened there. It said all of a sudden that I was trying to connect.
No worries. We were just, well, I was going to talk one or two questions, but it looks like you're back on. I think you were at the splinting slide, was the
Yes.
second splinting slide.
I'm going to go to that right now.
So while Dr. Leber gets this going, for those of you, particularly those of you who aren't in emergency medicine, one thing that's been coming up in the research a lot for those of you who have not rotated yet with peds is buccal fractures, and should we cast or should we not? And there's more research coming out about maybe not casting and using braces, except for compliance purposes and to satisfy parents. That might be something you guys want to ask Dr. Leber when she finishes her slides, but peds and fractures and casting or not is a kind of a hot topic right now.
I mean, thank you so much. And I'm sorry, I don't know what happened there, but I missed kind of what the whole conversation was. So maybe we could touch on that at the end really quick. But anyway, I was asking you just the reason why you want your MCPs to be flexed and your PIPs to be extended has to do with not losing function. if you were to cast or splint the hand with the MCPs extended, then you would not be able to flex the MCPs because they would get a contracture. So you want to keep those ligaments stretched, and I'll explain that coming up. So the difference between splints and casts, splints are open and casts are circumferential. Splints can better accommodate swelling, and so you want to use those more in the acute management of fractures. And if you're going to use a cast in the acute management of fractures, you want to bivalve it, which means you put the cast on, you allow it to harden, and then you use a cast saw to cut open a line on either side of the cast so that it's an open configuration. People like casting, and the reason to bivalve it, I should mention, is that it's biomechanically stronger than a splint, so people feel it holds fractures better. So you want to make sure you do a good physical exam. This is a picture of someone who had a ring on, and they had a wrist fracture, but the whole hand swelled, and you can see we had to cut the ring off using a ring cutter because the hand swelled so much. So make sure that if they have any kind of jewelry on, you pull that off right away and do a good physical exam. And so one thing I'd said at the very beginning of the talk is if someone has a hand injury, you want to get hand x-rays. If someone has a finger injury, you want to get finger x-rays. And the reason why you want to be so careful about this is because you will definitely miss injuries if you don't get the right fracture, and someone will come after you. If you don't get the right injury, excuse me. So you want to get the right x-rays. So these are all the splinting supplies you need. And the technique you want to use is first to apply a layer of stockinette. And you want to make sure you avoid wrinkles. You cut a hole for the thumb or any digit. And then you want to lay it on carefully so that there's no wrinkles and it fits smoothly right on the joint. And because it can cause a pressure injury if it's too tight. So we want to be loose enough. Then you apply a protective layer of cotton. And you want to make sure there's 25 to 50% overlap. You shouldn't be able to see any of the skin through the cotton. Pad any bony prominences like, the ulnar styloid here. Avoid any wrinkles in the cotton. And then you want to select and measure your splinting material, whether it be plaster or fiberglass. Measure it on the unaffected extremity. Use 8 to 10 layers. Use lukewarm water. And the reason you want to use lukewarm water is if you want to have enough time to mold the cast, but not too much time that it takes a while to harden, not too hot that it can burn the patient. And if it's cold, it'll harden too quickly. And if it's hot, it'll burn them and or not harden quickly enough. So lukewarm is your best bet. Smooth the plaster and mold it around to fit the contours of that joint. Make sure you're using your palms to mold it, not your fingertips, which can create pressure points. And respect the position of function that we talked about before. So, and then once you have the plaster on, best to apply a layer of cotton on top of that. And that's so that you can remove the ACE bandage more easily. And then you're applying your ACE wrap, not too tight. Make sure you're also laying that on loosely because it can cause a pressure injury if it's too tight. And so I'm just going to quickly go through the different types of volar splints and the indications. So you use a volar splint for wrist sprains, non-displaced distal radius fractures, triquetral avulsion fractures. You can use a volar splint for almost everything, especially non-displaced. Make sure it's not going further than the distal palmar crease. So if you look at your own hand, you want them to be able to flex their MCPs fully. And so the splint should not go beyond that distal palmar crease. We already said all that. An ulnar gutter splint is used for fractures on the ulnar side of the hand. Immobilize up to the DIP joints, especially for the metacarpal fractures, like a boxer's fracture, for example. Make sure that you have the correct positioning. And then this is where I was talking about why you want to extend the PIPs and flex your MCPs. And that's because you're likely to get contractures based on the ligaments and the collateral ligaments and the extensor and flexor tendons. Radial gutter splint fractures on the radial side of the hand. Immobilize again up to the DIP is much less common than the ulnar gutter. And then thumb spica splint is for scaphoid fractures, many carpal bone fractures, but especially thumb fractures and thumb phalanx fractures and similar positioning. Although with these, a lot of times it's good to have them hold a can or pretend like they're holding a can so that they maintain the proper position. And the sugar tom we talked about has its negatives because it immobilizes the elbow. So it's better used for fractures that are highly unstable, where you don't want them to be able to supinate and pronate. Said all this, yep. Okay, and I'm of course not covering every splint that exists, just the ones that really applied here to this talk. Okay, so here's some pictures of bad splints, and we see these all the time. I love my ER colleagues and my urgent care colleagues, but sometimes we see some pretty bad splints. So this is too much cotton in there. This is a splint that doesn't go far enough. If you're doing a sugar tongue, which is what this is, it definitely should go to the distal palmar crease on the volar side, and on the dorsal side, it should go to the MCPs so that they have full range of motion of their MCPs. So this splint is not really doing anything. All right, common pitfalls. You don't want the web roller cotton to be too tight because it can cause pressure or skin breakdown. You want to make sure that you're laying on your wrapping and make sure it's on loose enough. Oh, I think Jason is screen sharing. Am I done? Okay, I'm going to go back to sharing my screen. I think Jason did that by mistake. Okay. So make sure you put a careful neurovascular exam after putting on the splint, get repeat x-rays. If you have too little web roll, then you can get burns or skin irritation. So make sure you do not see the skin through the web roll. And make sure you respect the convexity and concavity of the relationships of the joint. Too much web roll is not good because you won't be able to immobilize anything because they'll be able to flex and extend and move against the cotton. When you get your x-ray, there shouldn't be a large space between the plaster and your soft tissue, or plaster and your skin. There should be almost no space. And that's what I wrote here. Critique your post-splinting x-rays. And of course, over immobilizing will lead to stiffness. So only immobilize the joint that you need to immobilize and no more, no further than that. And that is it. And I see that there's one question in the chat. Oh, sorry. Jason said he was frozen. Okay.
Yeah, my computer does that sometimes.
Apparently mine is having issues too.
Does anybody have any questions? So this was awesome. This was really good. This is a good review for everyone, whether you were trained in emergency medicine or other backgrounds. First question the next question from Peter, should we always get post-casting or splinting x-rays?
Yes, you should definitely, especially if you reduce it. So if there's been no reduction, you literally just put on a splint. Our orthopedic colleagues would love to say, yes, always get post-splint or post-casting x-rays. But if you literally have not reduced anything and they were non-displaced fracture, it's not super necessary.
So while we wait on the next question, something I was bringing up and some of my pediatric orthopedic colleagues down at UF are doing studies on is the whole buccal fracture, even green stick. Do you even need a cast at this point? Or can you just use a brace, like an Apollo neutral brace? Yeah, so actually all the evidence, especially for the buccal fractures, is showing you don't really actually need any kind of cast or splint. You can use a Velcro splint very easily. In fact, I had 2 buccal fractures while I was working as camp doctor at a sleepaway camp in New Hampshire recently, and just used a Velcro splint, and they did great because, I mean, they're all going to heal even if you don't touch them. Those fractures.
Is there any harm to doing it though? If there's like pain, like the pain is the indication, if someone's, if a kid is having a lot of pain and you want to just immobilize for just a hot second?
No, definitely no harm as long as you're only mobilizing the wrist, the joint, which would be the wrist in this case, but definitely no downside that I can think of.
All right, fair enough. Thanks.
Yeah, no problem.
Andy just put into the chat for everyone the survey, if you could all fill that out at your convenience. One thing I didn't see on there, and I know it's going to come into practice, and for those of you who end up taking care of fractures, Dr. Leber, how would you want to immobilize someone with a DRUJ sprain or minimally displaced to non-displaced DRUJ injury?
I mean, I would probably just do a volar slab splint to prevent flexion extension. I mean, you could also do a thumb spica so they don't allow as much pronation, supination as well. I guess it depends on how much pain they're having. But either a volar, a slab, or a thumb spica.
Alan asked thoughts on those. I don't know which question you're referring to. Thoughts on those on the field aluminum splints.
I think he's saying like there's ones that like come in the athletic trainers have. Maybe he's talking about yeah.
Oh yeah.
Are you talking about finger splints, Alan, or the ones that are like oh my god, I'm forgetting the name of it, but they're like prefabricated. So all those splints, okay, so especially the finger aluminum splints, we all carry them in our offices because they're cheap. And so we don't always carry the fancier splints. It depends on, I guess, where you practice. But the aluminum splints for the fingers come with too much padding. So cut out that white padding because that way you can really mobilize them better without the padding. If there's too much padding, then they can always flex and extend their fingers against the aluminum splint. Also make sure you're cutting it to the appropriate length. So if there's a PIP injury, make sure you're only immobilizing the PIP joint below or above, depending on what's indicated. And same goes with the DIP. You don't want to then include a huge long splint and immobilize the MCPs and everything that you don't need. In terms of for other joints, obviously it's very hard to mold it for any kind of fracture. So I would just use those very temporarily to get them to get to X-ray because that'll help with pain control because it'll at least support them. Hopefully that makes sense. No problem.
Any other questions? We have about 5 more minutes or so. All right, Dr. Leber, any last thoughts or suggestions or tips in a very nice 45 minutes or so?
Yeah, when I first started practicing, I actually got, there was a fracture management book. It's like thick, and I referred to it a lot in the beginning, but I would say don't shy away from managing fractures because the more you do it, the more you become comfortable with managing them. And you can always ask for advice from different colleagues across the country or even in your own practice. You know, just text pictures to one of your orthopedic friends or to any of us, and they can tell you what they think it needs. Because the more you're comfortable managing it, the more you'll be able to do it in the future. But as soon as you shy away from managing fractures, you're going to refer out every single fracture. And what's the benefit of managing fractures? Because you're probably like, why should I have the hassle? Well, one of the benefits is that it's nice to be able to take care of everything. But the other benefit is for billing purposes, billing a CPT code for fracture management is actually really good, you know, beneficial for you financially.
Well, if there's no more questions, thank everybody for logging on. Dr. Leber, again, this was awesome. This was really good. Please, everyone, fill out the survey that Andy Meyer put in the chat about 5 folks above from all the thank yous that Dr. Leber is getting right now. And we will see you, I believe the next talk, Nate, it's next week, right? I just called Nate out. He probably isn't in front of the computer. Oh, there you are.
Yeah. Sorry. Yeah, Nate here. We've got, I believe we've got my, sorry, next week.
Sorry, I put you on the spot. I think the next one is on the 27th.
Sure did.
I haven't announced it yet.
Disorders of the athlete's spine. Yeah, we've
Gotcha.
got Mark LaValle. Sorry,
Gotcha.
I've had a few other things.
Look, you can say you're watching the Dodgers game. That's cool.
Reviewing a case report. But thanks, Melissa. Great talk.
No problem. Thank you for having me.
All right. Good night, everybody. Or at least on the East Coast. Good night, everybody. Have a good one.
Good night.
Good night.